Hey guys, it's Lieutenant Krivjanik. I'm here with Dr. Roach. Want to go over the 2022 annual review for the EMS action items.
Hey everybody, this is Roach. Looking forward to this discussion. We've had a lot of amazing stuff that's happened over 2022, and we've made some protocol changes. So we just want to take the opportunity now to kind of go through some of these things. And Steve and I are just going to have a dialogue, right? We're going to go through this. Okay, let's do it.
So I wanted to give you guys some feedback on the previous action items we had last year at the end of the year. One of the first things that we talked about that was high acuity and just in high attention overall was report writing. Some of the things that we've addressed with report writing, specifically in CPR and cardiac arrest report section of the report, was people putting AED for when they were actually using a monitor and not documenting whether or not they had an ITD on if they were using the rescue pod. Happy to say that you guys have listened and heeded the advice and made significant changes with that, and I appreciate all you've done with that. The other thing is with QSOFA. QSOFA and sepsis is huge. Unfortunately, ESO does not allow us to make that a mandatory form, but I would appreciate if you guys in this next year would really focus on documenting whether the patient was QSOFA positive or not in the form section of the EPCR.
Let's talk about why is the QSOFA so important. Fire rescue calling sepsis alerts. Right now I know that most of the hospitals don't really receive those sepsis alerts as you would like them to. And that's on me to kind of go through the hospitals and discuss it. And I've been talking to Broward Health about, I think if we can hone our skills with the QSOFA and appropriately call sepsis alert for the ones that are QSOFA positive, the background there is those are the moderate to severe sepsis, okay, or septic shock. Those are definitely sepsis alerts. In the past, there was SIRS criteria. If you got 2 SIRS criteria, you're calling sepsis alert, and the hospital will downplay some of those because there's actually not truly septic. But a person with a fever with 2 QSOFA criteria, that's the real deal, and those are the people that have a high mortality, so we got to get on that. But it is a group effort. It's not just us in fire rescue, it's also the hospital. So our piece of that would just be really good at documenting the QSOFA.
Right, and we've talked about before, we want to get to a point where, you know, when we call a sepsis alert, when BSO Fire Rescue calls a sepsis alert, that they take it just as serious as when we have a STEMI alert.
Yeah. And
we have a team there. If we don't use the QSOFA criteria, what happens is it gets so watered down that they go, okay, well, it's every person has a fever and it's tachypnic.
Yeah.
I've changed the way I'm doing stuff too, and if you guys could just look at that, first thing we do is put on an end-tidal CO2 if they're less than 25. That should be a great indicator of that, hey, I need to look at my sepsis criteria screening form.
Yep. Back to report writing, I just also want to say, looking at the narrative when I review reports, we do a really good job of the narrative. I mean, some cases it could be a little bit better, but honestly, I've seen a tremendous improvement, so thank you.
I agree, and I second that as well.
Okay, so now TPOD, let's talk about stabilizing bleeding.
Dr. Roach and I were talking about, we always have these discussions about protocol changes, equipment changes, medication changes, what we shouldn't be doing. And one of the things that comes up constantly in traumatic arrest when we go to the medical examiner's office is that there's an opportunity to fix or at least identify a pelvic fracture. And we talk about how hard that is to be able to do sometimes. Unless it's an open book fracture, it's really complicated to do. I went back and looked in the last 3 years, we actually used the T-pod 7 times. Out of those 7 times, it was successful. So I think that, you know, what we need to take away from that, what we did take away from that is that we need to start training on that piece of equipment a little bit more and getting it out to let people know, hey, listen, especially in traumatic arrest, if you have a person with traumatic arrest, especially in blunt force trauma, put that T-pod on. They might have a pelvic fracture that you can't identify. Right?
Exactly. Yeah, that T-pod could save a life for sure, and it's difficult to diagnose that. But, you know, in some cases, it's easy to diagnose a pelvic fracture if it's unstable, and the symphysis pubis is widened, those kind of things, but I don't expect you to diagnose that. It's really just having a low threshold of the clinical suspicion for a pelvic fracture and just put it on. The other things are using clotting agents, tourniquets, direct pressure, that stuff, because now we're giving whole blood and TXA, and I don't want to lose sight of the basic stuff, you know, and so that's a key thing, is to stop the bleeding and from the external with tourniquets and direct pressure and quick clot and T-pod. Think of that all in a bundle. And then we also the next step is all the other amazing things we do with TXA and whole blood.
Right, and finger thoracostomy, and especially you know relieving that tension pneumothorax is huge, and that might be an option for reversal for that traumatic arrest.
Next is the PIC crew CPR. and high performance CPR, that's come a long way over this 2022. Man, I remember looking at charts and reviewing, and there'd be delays in epi, delays in defibrillation, pauses in compressions, and those things are a thing of the past. And well, for the most part, we'll always have to stay diligent looking at it. We were just talking about our ROSC rate for last month.
Yeah, last month we got 52% ROSC rate.
Wow.
And that's just a testament to you guys staying on scene. I didn't look at one chart last month in the month of January that you weren't on scene longer than 20 minutes, and we're seeing an uptick in you guys getting more comfortable with after 20 minutes of CPR and ALS interventions, if they're asystolic, to pronouncing them on scene.
Yep,
and
absolutely.
that's what we need to get behind, and you guys are doing a great job.
Absolutely. Okay, and then the next point was the whole blood and
EMS
considers that is actually, we've had a lot of cases where EMS 17 is intercepting and air rescues being called, auto launch, and even other agencies are doing this now.
Yeah.
Because they see our success.
Yeah, we just administered our 88th unit last week with TXA, and they're all survivals.
Yeah, I know.
It's just incredible.
It's astonishing. The data really on the highest acuity patients with trauma, the severity index, cardiac index is the highest. Those people tend to survive. As a matter of fact, most of them survive.
Most of them.
Yeah.
I think all of them.
Yeah,
all of them.
Yeah. So back to sepsis, the fluid bolus is key. That is a key thing. And sepsis, Q-SOFA positive, those people are unstable, and getting that fluid on and resuscitate them is extremely important. So stay diligent with that. And then epi and cardiac arrest. Really, we've talked about during the 2022 timeframe, we talked about epinephrine. We looked at the data, and the take-home message is early epi increases ROSC.
Right.
That's the key. And too much epi actually can decrease neurologically intact survival, which is the science behind our epi drip, because we're trying to make your job easier. So the epi drip is ready. You could come on scene, drill the IO, drop your epi drip, and the patient's now getting epinephrine. Over the course of 2022, there were some cases where there's actually trials going on now where they do one and done, where they give 1 milligram epi and stop. So these are all things that are happening around the country, and our epi protocol actually is really state of the art. I brag about it constantly because what you all are doing is really cool, and it actually includes pediatrics too, which I think is great. We really have to deep dive into the data and look at how our ROSC rates are and how our neurologically intact survival is with pediatrics specifically. We'll do that in 2023. Okay, so we're going to go through some of the protocol changes. The first protocol change would be the addition of TXA. Currently, TXA is going to be with Air Rescue and the EMS 17. We do have plans to extend this to the entire agency. We're just settling this out initially with those 2 units. The way TXA works is it's an antifibrinolytic, and it stabilizes the fibrin clot, so it'll decrease bleeding secondary to trauma. TXA is most effective when given in the first hour. You'll see literature, you have up to 3 hours to give it, but it's best given in the first hour, which is why it's a pre-hospital drug and highly studied in the military. It has a decrease in mortality for traumatic arrest or traumatic shock, as well as brain injuries. Yeah. So those 2 things are huge. Just a little bit of information on how to give it. It's 2 grams. We're going to put it into a 100 milliliter and the 10 drop set, but it's going to be 3 drops a second, so it goes in over about 5 minutes, something like around that. And then you can see in the protocol too, there's a dosing for pediatrics. It's in the med tool. We're going to update into the Hantevi as well, so it'll facilitate dosing. But as you can see there, 5 to 11 years will get a pediatric dose, and 12 and above get the adult dose. Anything else that you want to talk about there? With the TXA?
I think it's going to be great that we're using this, especially in head injuries and air rescue. That's probably one of the most common calls that they have, especially in pediatrics. Why does it work in head injuries? I understand the process in hemorrhagic shock, but can you talk about why it works in head injuries specifically?
The why of it really, it's stabilizing the bleed. So when you bleed into the brain, that trauma that's going through the brain, it's once brain tissue doesn't regenerate, right? So anything you can do to minimize bleeding in the brain is going to be extremely helpful. Okay. There's other discussions about anti-inflammatory properties of TXA, and so those all could be
swelling.
Yeah, with the swelling.
Takes down the swelling,
yeah,
right? Is that true?
Those are theoretical things that might be happening, and some of these things. That's why we do trials to test to see how things work. Okay. But primarily, when you think about TXA, it's to stop bleeding. so the brain is preserved.
Awesome.
So that bleeding that occurs, we can stop that fast.
The only other thing that I had was I had a question when we first got it. We were back ordered on the 100 bags of saline, and the question was, did you mind if we gave D5W with it? And I think we've already answered that it was okay. There's no difference, right?
Yeah.
It's okay.
It's not an issue if you had to give it. I would probably avoid the D if you could.
Right.
There's other issues possibly with that, but if you didn't have another fluid to put it into, you could put it into D5.
Okay. The next protocol that we've made a little changes to is the CHF protocol. One of the biggest changes was the removal of nitroglycerin tablets and the addition of Lasix 40 milligrams IV for an adult. Dr. Roach, can you talk about some of the discussions on why we brought that back and why it's important?
The Lasix, yeah. So Lasix, I think of Lasix a lot like Solumedrol, that it's not really an emergency medicine drug. You're not getting that effect in the beginning stages, the first 30 minutes or an hour. In most cases, Lasix doesn't work that fast. However, even at the hospital now, in talking to some of the cardiologists, they're starting to measure the arrival to Lasix time, because what happens is this is a drug it's taking 3, 4, 5 hours to give it, and we want to get the process started for CHF. So if you think about congestive heart failure, the therapies that we have, actually CPAP and nitroglycerin are the two things that are going to stabilize them the fastest. So that has to be still the priority. But just like Solumedrol, we want to get the Lasix on board so that they start the diurese much sooner than they would based on when the ER would actually give the medicine. So that's the reason why. And then just to uniform this throughout the county. I think it's just going to be a benefit for the congestive heart failure patients.
Right. The next one that we made a little changes to was the stroke protocol. So prior to this update, we had in the protocol a stroke patient must receive a 500 milliliter bolus regardless of blood pressure. I know a lot of you guys out there got messages from all of us saying, hey, why didn't you get 500 bolus? Why didn't you put why did you put them on oxygen? Can you talk about why we decided at the end of the day that just wasn't worth the fight to keep doing that?
Yeah, the reason why is because when we go to the hospitals don't really endorse it. And I'm not saying that the 500 cc bolus is wrong. I actually think it's a good idea to do it.
Right.
But enforcing it into the protocol, that's another question. So when we go to stroke neurologists and specialists, there are stroke neurologists that agree with that we should do that. But there are some that say, we don't know if it really matters. There's small studies that look at this. This is not like a class 1 evidence, like that you really have to do this, otherwise you're causing harm to a patient. So when these kind of things come up, I don't really want to have this in the protocol that causes confusion. So we've had a couple of issues where this caused confusion. And so look, this kind of goes in the same category as remember we used to have all stroke patients will be in the supine position.
Yeah.
And then and there is some there's similar stuff with that.
Yep.
There's in Palm Beach County actually still does that. So I agree with it that it's a good thing, but it was causing some troubles because we had some people aspirate, and then the crews were asking, hey, shouldn't the patient be at 30 degrees? And then the hospital wants them at 30 degrees. So with these kind of things, I think it's better to kind of mesh with the hospital, and these are not things I'm willing to fight to change. However, I do think that giving the 500 cc bolus is still a good thing to do. As it says in the protocols, you can actually put the person in supine if the symptoms improve. Leave them there if it's safe, but you have the discretion in terms of the positioning of the patient.
Awesome. The last thing I wanted to talk about real quick on that was the oxygen administration in a patient that's having a stroke. So we've had some questions recently about, hey, listen, man, I got a guy or a lady that's tachypnic. She's breathing 28 times a minute. She's hypoxic fighting, or appears to be. Some of the thought is like, hey, can I put her on oxygen? We have it in our protocol, right? To not withhold oxygen. Is that an okay thing to do? If I have a patient that's got a 96 O2 sat and she's end tidal of 25 and she's breathing at 26 times a minute, is it okay to administer some oxygen to her?
Yeah, it is. It is. And so let's go back, get the background of what this whole was intended. The whole idea of what oxygen was intended for. We all learned Mona, right? Yep. So everybody learned anytime somebody has chest pain, slam them with oxygen. And so we just reflexively started doing that, and not really thinking about, how does this help? Is it harm? What's the deal with oxygen? And we learned that oxygen is not helping anybody, right? So then when you make a protocol, you say don't give oxygen, then you have to have a clarifying statement. Don't give oxygen, but at the same time, don't withhold oxygen for people who need oxygen. Right. So you're the clinician that's seeing the patient. If you feel I felt the patient needs oxygen, give him oxygen. Okay, and no one's gonna give me a hard time about it.
Yeah, 100% agree.
That's the final. That's the final. I'm
Yep.
the clinician. I was caring for the patient. I felt my patient needed oxygen. Give him oxygen.
What
What we're trying to save you is, on the other hand, I'm the clinician. I don't think the patient needs oxygen. Don't give him oxygen.
Correct.
That's what it's really intended for.
My only hope is that when you do make that decision to give that, just document it clearly.
Right.
You know, there's not going to be any question if you document your narrative that this patient was in a tripod position with pursed lips and was tachypnic.
Yeah,
right.
Absolutely.
So, okay.
I've had patients that have pulmonary embolism that are satting 98%, but I'm looking at them breathe and I'm going, they need oxygen. As soon as I put a couple liters of oxygen on them, they feel much better. So that's a positive thing. There's nothing wrong with that. You know, that's why the protocol is written that way.
With the hospital capabilities matrix, I get a lot of questions on this, and I see a lot of potentials for opportunities that we can improve on. Specifically, I just give you an example. I'm in Deerfield. I got a 12-year-old male, slips and falls on a scooter, breaks his arm. Doesn't meet a trauma-like criteria. I see the rescue going en route to Broward General. So can we just, there seems to be confusion about what exactly the names at the top of this chart actually mean. And I know that you and I have had discussions about this before, but I want them to hear it from you so we can try to get this out.
This is a good discussion because this is definitely there's a lot of controversy from this. So your example of the pediatric patient, the 12-year-old, now that age, 12 years old, is another thing. So, and it's great because it's not, we haven't put it in the protocols, and it's very difficult to write a protocol. If you're 12 and you broke your elbow, go to the closest ER, right? Because they can do an x-ray, they can splint the 12-year-old, and they can refer him to a pediatric orthopedic surgeon.
Correct.
If they needed to transfer, they can transfer. So it's not a deal breaker to take a patient like that to the closest ER.
Right.
The matrix reads pediatric admit. That's the information that you're given. So our protocols are specific when it comes to cardiac arrest, pediatric cardiac arrest, that if we get ROS, they're to go to a comprehensive pediatric center. That's very specific because we don't want a pediatric patient. So for example, an 8-year-old, cardiac arrest, we get ROS, and then we take them to a hospital. We know for sure they're going to transfer. That's the intention.
Correct.
So with these kind of things, in the beginning, if you have a 4-year-old who's got a fever and you're taking them to the hospital, and you think they look pretty ill and they're going to be admitted, that might be the one you say, I'm not going to save this family I'm going to just drive them down to the medical center where they can get admitted if they need to be. So you really have to think, and if you have concerns or questions, I would reach out to the EMS captain or the lieutenant or myself on those cases. So that's the pediatric.
I think that's a pretty common one. I worked overtime not too long ago and took a psych patient in North Broward. It's immediately like, oh, why are you going here? You know, and we talked about that, and it's like, they do not have to go to a psych facility.
Correct.
They can go to the closest facility, and then it's up to them to get an accepting place somewhere else down the line. You know,
100%.
If you can justify taking that person to a place that's within reason, then fine.
Right.
But that doesn't mean that it absolutely must go here.
Correct.
Right.
Yeah. Now, and so look at Weston. Weston, that whole battalion takes patients to Cleveland Clinic. All the psych patients go there.
Right.
They don't go out of their zone. So that's another example, and that's perfectly reasonable. Now let's talk about the cases where it is directive. Like for example, a trauma.
Yeah.
If it's a trauma alert, now you follow the matrix. You have to go to a trauma center. So they're listed there. If it's a stroke alert, you have to go to a stroke facility. So there's yeses and nos. We made it easy because there's a lot of discussion in the community about thrombectomy capable, if you're Joint Commission comprehensive, if you're DNV comprehensive, all these categories. You don't really need to know that. We made it simple for you. It's a yes or no.
Right.
We're saying even if you're thrombectomy capable, like Florida Medical, Holy Cross, Cleveland Clinic, you should take stroke patients there for now until we're looking at the data. That's an important thing. STEMI centers. You need to go to a STEMI center if you have a STEMI. That's straightforward. It's in our protocols. All cardiac arrest patients go to a hospital that has a cath lab. So that's in the protocols. You follow it. Now whole blood is informational. That's these are hospitals that carry whole blood. That doesn't mean that you only take patients. If you give whole blood, you have to go to one of these 3 hospitals. That's not medically necessary that they have to go to that hospital. However,
when we're talking about the chest pain protocol, the last couple quality management meetings we've been discussing that, I read a report, and over the last year in STEMIs, specifically STEMIs that had chest pain, no patients received fentanyl. And we talked about how damning that is to the patient's recovery, and how how stressful they already are, and how we should have been doing that. And one of the things that came out of that was this nitroglycerin. Nitroglycerin was given almost every single time. Aspirin and nitroglycerin, and they were transported every single time. And we talked about, is it effective to give just nitroglycerin, or why are we even giving the nitroglycerin?
The chest pain, let's talk about the chest pain protocol. Thinking about these things, when you have a STEMI, what are the critical actions that actually decrease mortality? The first and most important thing with these is encoding in the EKG to the STEMI center so that they are prepared. Because what we really have to do is door to groin, door to balloon is the key thing that's going to decrease mortality in this patient. The other thing that's extremely important to decrease mortality, aspirin. Okay, giving aspirin has a mortality reduction, and it takes that off the table for the team, and they can give other things. So the two things we can really do to impact the patient is get them to the cath lab as fast as possible. That's the most important thing. Aspirin, and then now the question about nitroglycerin. We've talked about MONA and how MONA really, a lot of the stuff in MONA, and specifically the nitroglycerin, it doesn't change mortality or morbidity. So it's not like you say, well, if I give nitro, it's going to increase this person's chance of survival. That does not exist in the literature. The other thing that doesn't exist is if I give nitroglycerin, it'll decrease the size of the infarct, and they'll have a better functioning heart because of the nitroglycerin. That is not true. So nitroglycerin should not be considered as a therapy that reduces mortality or morbidity with cardiac ischemia. Okay. With that said, you have a lot of downside by giving nitroglycerin. You can cause hypotension, and whether it's an inferior wall or an anterior wall or lateral, and all STEMIs have the possibility of becoming severely hypotensive with nitroglycerin. Right. So why not give, for pain control, give fentanyl. It's humane, you give fentanyl. If the patient's vital signs support it, give fentanyl. So, and it also makes your job easier. Focus on the thing that's actually going to save their life, which is getting them to the cath lab. Encode the EKG, communicate properly, and get them to the cath lab. Aspirin and then good pain control is the key. The rest of the stuff is not going to be helpful for the patient. The oxygen, we have that there. Oxygen doesn't decrease morbidity and mortality, especially when their O2 sats above 95%. So you don't have to do that. And again, this all falls into the concepts of making your jobs easier and improving outcomes for the patient.
The hemorrhagic shock slide that we're talking about in this presentation is pretty exciting because we changed some of the things that, in my career has been like, this is all we can do in trauma, right? And that was 2 large bore IVs, as much saline as I can give these patients as fast as possible, up to including 4 liters. And we've learned over the years that what they actually need is whole blood, right? Blood is for bleeding, and salt water is for pasta, and that should be stamped on all of our med boxes, because at the end of the day, that's really what we need to do, is restrain from giving all this saline, and we want to keep them in a permissive hypotensive state. So Dr. Roach, would you mind speaking on that?
Absolutely. Yeah, so we all learned 2 large bore IVs, but what's the purpose of two large bore IVs? In the past, it was fluid. We're going to give lots of fluid, crystalloids, but we know that's not the answer. So there's no reason, unless you're going to intercept with EMS 17 or you are EMS 17, then you may want to put a large bore IV and get ready for blood transfusion. It takes an enormous amount of discipline to withhold crystalloids and allow a patient to be hypotensive. But that's what we need to do in trauma. Until we talk about this, until they become altered, until their mental status starts to deteriorate, then you can consider giving some crystalloid. It's a last-ditch effort. But for the most part, we want to avoid crystalloids in trauma patients. Now, the other key thing is what you can do is stabilize bleeding. So a T-pod, tourniquets, quick clotting agents, direct pressure, anything and everything you can do to stop bleeding until you get the patient whole blood or to the trauma center.
This is a hot button topic for a lot of us, and we see this in report reviews a lot, and that is the H's and T's. So we were all, trained on ACLS at one point in time, where it was like, listen, H's and T's, right? If they're down, or at least when I got hired, if they're down greater than 20 minutes, they need sodium bicarb, man. They're metabolic acidotic, So if they're in a cardiac arrest and they have an IV, a needle sticking out of their arm, they just got done doing heroin, they need as much Narcan as I can give to try to reverse that, right? I just wanted to clarify with you, if you could provide some clarity to the field of why that's just not necessary. right?
Yeah,
We
yeah.
need to do the things that's necessary for the patient and not unnecessary.
It's all about priorities. And so our priorities with cardiac arrest are the things in our PIC crew. It's good chest compressions, never pause chest compressions, managing the airway appropriately, using the IGL, and all the things in our protocols that are in the cardiac arrest. Once somebody's in cardiac arrest, Narcan is not going to be effective.
Right.
Giving Narcan to somebody that's in cardiac arrest is really should not be on the first 5 bullet points of the things you need to do. As a matter of fact, until they get a pulse, Narcan really has no role at all in the cardiac arrest. So focus on the things that matter. Prioritize what you're doing. Bicarb also. There's no mortality benefit from bicarb. Give that after you've done all of the things in the PIC crew. The person's on the auto pulse. You've stabilized as best you could. En route, if you want to, the reason this is here is to start to think about what could have potentially caused this, and think, is there anything you can give to reverse the arrest? Yeah.
Yeah, we talk about it. It's actually you brought this into my attention. I love it. It's what do we need to do to fix the problem, and what are the stop points, right? What do we need to do to fix the problem? It's high quality CPR, epinephrine, early defibrillation, get in an airway and all that.
Yep.
And listen, if you're now you got some stop points and it's not working, it's a last ditch effort, right? But Narcan specifically is like one of the things I see all the time. It seems to be that a lot of guys will just be like, we're at our wits' end. Let's just dump the drug box. We give sodium bicarb, we give calcium chloride, we give Narcan. And we've talked about, just doing things for unnecessary reasons just to do them is not how we practice medicine, right?
Correct.
We should be waiting until they get a pulse back to start thinking about, the Narcan.
Yeah. The interesting part about it is if you did get pulses back and they started to wake up and they're in the emergency department of the hospital, I'm going to sedate them with propofol and fentanyl. So even if you give them Narcan, if they do wake up, I'm putting them back on a fentanyl drip to stabilize that, to give them comfort while they're on the ventilator.
Yeah, exactly. It's a great point.
Yeah.
Yeah. So it's like, why are we so concerned about that?
Yeah.
It doesn't matter. Right.
So coming to a close for this presentation and talking about everything that's happened in 2022, I just want to say thank you to everybody listening to this. This agency has come a long way, and we continue to make strides, and we're gonna continue that in 2023. But I'm very proud of everybody, and I'm grateful to be the medical director of this agency. And just looking at the cases in case reviews with cardiac arrest, and the way we manage trauma, and just the way we do things, it's exceptional. So I hope that everybody realizes how good you are and what a difference you're making in the community. Let's keep it up, and let's make 2023 a fantastic year. Thank you all.
Yeah, I appreciate you saying that, Dr. Roach. And one thing I just wanted to add to the end of this is that a lot of the stuff that comes out of the data that comes out of these meetings that makes these action items possible happens in our quarterly EMS quality management meetings. And because of COVID, they were closed meetings, but we just got done talking about today about bringing them back in public. And I'm going to highly encourage you guys to come to those meetings, get your input. And this is not a browbeating session. This is a learning opportunity, and we learn so many things about how the agency is performing overall and how individual people are performing. So I encourage to see when you guys get notification of that to make your way over to the meetings.
Yeah, we'd love to see you there.